Let's welcome everyone. Happy to be with you. Let's start with one of the cases that Dr. Lin has shared with me from her laboratory. This is a breast biopsy case, and we have a number of immunos, and the patient, I believe, is 60 years old. Let's see, get the... And then we will turn on the captioning so everyone can see the words as well. So here is the needle biopsy. As you can see, several sonometers. This was a 2 centimeter mass. And as we come in and look at this, one of the first things we note here, right here, is the presence of lymphatic invasion. So that's certainly a risk factor if this is a primary tumor, and also raises the possibility of metastatic disease. We have several lymphatics here that are filled with tumor. The other thing that I think we would want to look at in this case, my mouse is not working very well. Would be whether or not we can identify areas of in situ type tumor. And so let's look around a little bit here. See what the rest of the tumor looks like. Here's more of what looks like lymphovascular invasion. And then we have some solid tumor, a little bit of lobular architecture. That has a bit of lobularity to it. But not definitely in a breast lobule type of appearance. Oops. The tumor is mostly glandular and a little bit solid, not too much. So in this case, I think the markers become very important because I think this patient also has a lung mass, if I'm correct. And looking through this, I didn't see, here's again, tumor lesion. And then I believe up here we've got some benign breast structures. But a little bit difficult to evaluate from that standpoint in terms of benign breast parenchyma. So we will go back out here and then see if we can go back and take a look at some of the other immunohistochemical stains that have been done here in this case. So here's a nice some of the fixed images. Again, gland formation and a few micropapillary type structures, which certainly the breast can give you in that papillary architecture of the luminal B tumor cells. And nothing here that really looks like a classical in situ type of lesion, intraductal or intralobular lesion. So our immunohistochemical panel showed a couple of things that were of note. And the first one is this: the TTF1 is diffuse and strongly positive. So there are many tumors that can have kind of patchy or weak TTF1 that are not primary lung tumors. But in a primary lung or primary thyroid tumor, to have diffuse and strong staining like this would be quite unusual. So this, together with the extensive lymphatic invasion, I think underscores the likelihood of a metastasis. Now, in contrast here, the ER estrogen receptor is quite weak. It still looks like it's positive, but it's very weak and would be a low Allred score. We use in our laboratory the Allred score, which combines the intensity and the proportion of cells that are positive to provide an 8-point scale of significance of the hormone staining. So 8 of 8 is a very strong stain, whereas something like this that's weak would get 2 points for the weak staining, and probably 2 points for the proportion of cells that are positive. So it would be a 3 or a 4 score out of 8 situation. So our clinicians find that useful and ask for the Allred score on our reports. Another ER, again, some positive, some negative. And PR is totally negative. And this is a little bit of an interesting dilemma, because usually in primary breast tumors that are hormone positive, the progesterone receptor is more sensitive than the estrogen receptor and will be more likely to be positive in a higher proportion of cells than estrogen receptor. So there again is a little bit of a suspicion that this is probably not a typical breast cancer, especially one that seems to be relatively, glandular differentiated type of situation. So I think the likelihood here is that this is a metastatic lesion from the lung that has come to the breast in this situation. This marker, GCD-FP15, is a marker that is fairly specific for breast cancer, but it's not highly sensitive. So if this were positive, it would argue against the TTF1, but by virtue of the fact that it's negative, we would not exclude breast cancer on the basis of a negative stain. But taken together with the negative TTF1, it certainly is consistent with that interpretation. So, Dr. Lin or others, do you have a comment on this case of breast tumor in a woman with a lung mass and funny immunohistochemical results?
Yes, I think so. If this is the breast carcinoma primary.
I don't think so. I think this is metastatic disease from the lung.
Yeah. I will spend more with the ATA3 and nothing for diagnose exactly about the lung cancer.
Yes, that would be a good idea, to do a GATA3 to make sure that's negative, and to include napsin A in your panel to strengthen the impression of metastatic lung cancer. So I thought that was a very good case for discussion and illustrating a common problem that, well, not common, but at least a significant problem for many situations. Let's go on to another case that Dr. Lin has submitted and discuss this case, which I believe is a tumor in the lung. Oops. There we go. It's going to open now. And do you want to just tell us the story on this patient again, Dr. Lin? I think yeah, I think
Yes.
you told me that this was a patient, a 37-year-old male,
Yes.
and he has a metastatic tumor in the brain, thought to be a sarcoma.
Yes.
So here is the biopsy fragments. As you can see, it's quite cellular. We have some normal bronchial epithelium along here. And then we have these cells which have very clear cytoplasm. See if we can magnify this a little bit more. There we go. A fair degree of pleomorphism. And maybe some of these are nested with a little rim of vessels around them, some hemorrhage, some big nuclear pleomorphism to some of the areas, and a little bit of discohesion in some of these clusters. So, although this patient is young, this looks like a clear cell neoplasm that likely is epithelial in nature. It looks very nested and epithelioid, that pattern. So things that can look like this most commonly are things like renal cell carcinomas. There certainly are clear cell tumors of the lung, although they usually don't have this degree of atypia. Those are usually more benign tumors, sort of sugar tumors they're called, that are really PEComas, PEComas, that have dual myogenic and melanocytic features like we see in other organs. But in this case, you did a panel that included a number of things, which showed negative napsin A, pretty high proliferation index, maybe 30 or 40%. No staining with vimentin, but certainly some staining in the stroma, indicating that your tissue fixation shouldn't be a problem. And negative with low molecular weight CAM5.2 keratin. Negative with muscle actin, so that sort of argues against a PEComa. And no HMB45 staining, so we've ruled out PEComas or clear cell sugar tumors. Your renal cell antigen is negative. This is not the most specific marker, but it's one of the better ones that we have for now. TTF1 is negative. So what are we to make of this? I assume that we did a pan-cytokeratin as well to rule out other types of carcinoma. But in the setting of a patient with a sarcoma and this type of morphology, there's a couple of things to consider. And one would be a clear cell sarcoma, which usually has some melanocytic markers, and this one did not. And alveolar soft part sarcoma can have this appearance. I found a nice example of alveolar soft part sarcoma in the files from the University of Toronto. So I thought this would be a nice primary tumor to evaluate and compare to this case that we have, if we can get it to come into focus. There we go. So here we see this, again, very clear cell pattern. With a degree of nesting. Let's see if we can maybe just move this over here. There we go. Okay, so that'll bring it into focus. And so this shows the more typical appearance of alveolar soft part sarcoma, where the nests are of variable size, and there's really a great degree of discohesion between these cells. They don't have the sense of connectedness that we're seeing to some degree in our sample, although they can be fairly closely packed here. And this sarcoma is usually negative for most markers that we commonly have available. It doesn't stain with muscle markers. It doesn't stain with melanocytic markers. It doesn't stain with any of the epithelial cell markers. But what it does stain is with TFE3. So that's an indication that this tumor has a fusion gene or a mutational change that is very useful for diagnosis. And just to reference also some of the materials from Pathology Outlines, I pulled that page up for your review to think about the differential of metastatic renal cell carcinoma, cortical carcinoma, hepatocellular carcinoma can have a clear cell variant and be packeted like that. Granular cell tumor, paragangliomas, picomas, melanomas, rhabdomyoma, rhabdomyosarcoma with an alveolar pattern. So any of those things might be considered in the differential. And so if we had something like that, and we had any of these other markers showing positivity, that would be helpful. Notice here that for renal cell carcinoma, they use PAX8. However, one thing to note here is that some of the translocation carcinomas from the kidney can show expression of TFE3. So there's a little pitfall there that could be dangerous if you only did a limited panel, and especially if you had any PAX8 positivity, that could be helpful to steer you this direction as opposed to towards alveolar soft part sarcoma. Dr. Lin, do you know where this patient had a primary tumor?
Professor, I don't know exactly about his history, metastasis sarcoma in the brain because the Da Nang hospital cannot provide me slide or block, and I don't know about that. And
Okay.
just about the primary tumor, I don't know. Clinical doctor don't show me about primary tumor, and
Okay.
in my department, part S and The FE3, I don't know. I don't have a graph.
Yeah,
So,
yeah.
Yes. It's
So
difficult
these are
to,
sometimes not widely available, but would be helpful. So I think you can presume it's consistent with alveolar soft part sarcoma, but you don't have a definitive diagnosis at this point for that. The other thing to mention here is, of course, the age group. He's in kind of a young, early adulthood age. And alveolar soft part sarcoma has a very broad age range from pediatrics to late adulthood. So he's certainly within the period of time when you would think of that. He's pretty young for renal cell carcinomas and for hepatocellular carcinomas. So some of those other lesions, less frequent, but certainly any of the sarcomatous lesions, rhabdomyosarcoma, and alveolar soft part sarcoma or clear cell sarcoma are within his age range of consideration. Any comments or questions? Dr. Ha, Dr. Dome, anything doesn't make sense? We also should. I'm sorry, Dr. Dome, say that again.
Yeah, I understand a little bit. It makes sense.
Okay, okay.
Thank you, Professor.
The other thing to just note here is that some of the PCOMAs can also be positive with TFE3. There's kind of a mixture of molecular events in those that sometimes can involve that fusion partner gene that is expressed as TFE3. So it's not totally specific for this diagnosis if you have a positive stain, but in the absence of other stains, it's certainly supportive of the diagnosis. So last month we held a whole slide review course here in the United States for the trainees who are going to take their board exams. So I was able to get the link to some of those cases. And I thought it might be just useful to run through those slides fairly quickly because they show kind of the core pathology in a particular organ system. And I have two ready to do. One is just head and neck pathology generally, and one is thyroid. So do we have any preference as to which one we begin with? Not hearing a vote, I'm going to begin with the head and neck lesions. These are both situations or cases that were shared by my colleague at the Moffitt Cancer Center in Florida. And I will be able to send you the link to these slides after we're completed. They also have some quiz questions, but just nicely cover the waterfront of the kinds of cases we might see. So certainly the most frequently encountered lesions in the oropharyngeal area are the squamous epithelial lesions. Here's an example of that, a keratinizing squamous carcinoma. You can see one of the classical features of invasion in that disease is the surrounding inflammatory change and this what we call paradoxical keratinization, the presence of this keratin little pearl here deep in the tissue rather than on the surface. That's a good marker for invasion. The irregularity of the outline here also is an indicator of invasion. And the inflammatory infiltrate that comes along with this also says I'm invading the tissues. This lesion here, as you can see, has a lot of associated muscle fibers down here. And that's because the most common locations for this tumor are along the edge of the tongue, and sometimes the base of the tongue. So you're going to get the the skeletal muscle of the tongue involved by tumor a fair degree of the time. Obviously, cofactors for this are smoking, drinking, betel nut chewing, and using oral chewing tobacco and those sorts of things that cause a chronic inflammatory and toxigenic or mutagenic environment in the mucosa. So this is not the only type of squamous carcinoma that we can see in the head and neck region. This is another example. In this case, you see the surface squamous mucosa here, and then we have a very blue tumor in sort of fragments that is solid and not keratinizing. It does have some degree of pleomorphism, high degree of apoptotic cells, and a few islands of keratinization, as you see here. This lesion is, as you see, doesn't have much of a surface dysplasia. In some settings, you might have some dysplasia on the surface, which you can see maybe a little bit here. But sometimes it just arises de novo or seemingly de novo from the basal epithelium with relatively little in the way of overlying dysplasia or atypia. This is an example of one of the HPV-related tumors. This is sadly becoming a more frequent disease over the course of time. I don't think when I was first in training that this type of tumor was very frequent, but it has become more so as we have continued to spread the human papillomavirus. In theory, vaccination would be able to prevent the majority of these tumors, at least those that are caused by HPV type 16, 18, maybe 31, 35, and some others that are included in the vaccine serotypes. So a P16 stain will help to identify these cases that have the HPV genome incorporated in them. And here you can see what that looks like. Not surprisingly, you have strong, blocky positivity, really in a very high proportion of tumor cells in this. So if you were to ask me, I'd say I'd go for 90% of as the cutoff for this tumor in the head and neck region. So another lesion that we can encounter less frequently in the head and neck, as well as sometimes in the esophagus and other squamous mucosal sites, is this lesion. So here we see some sort of warty-like changes, some complexity to the surface mucosa, and then a degree of atypia with some stromal alteration here. You can begin to see this stromal alteration, basal atypia, dysplasia sort of changes, atypical mitosis, some pleomorphism. And then as it invades into the stroma, you see that we get this sort of myxoid or loose collagenous stroma. And as we look further in this tumor, we see more spindling of these cells. Here you see some of these spindle-shaped cells, until we have these other fragments that are entirely spindle-shaped cells. And so here we see something that looks like sarcoma. It looks like a spindle cell neoplasm, very brisk mitotic rate, streaming nuclei, very atypical sort of appearance. And no question that this is malignant, but you might be thinking sarcoma. So if our biopsy only includes something like this, it's still important to recognize that these tumors will be cytokeratin positive. And if nothing else, doing a couple of cytokeratins would be valuable to make sure that we had not missed this lesion, because obviously treatment for sarcoma is going to be quite different than treatment for squamous cell carcinoma. And so making the diagnosis of sarcomatoid carcinoma is quite important. Now, fortunately, these sarcomatoid carcinomas tend to be exophytic. They tend to grow up and away from the underlying stroma or tissues into the lumen of the mouth, the larynx, the esophagus. So they will tend to form some sort of an obstructive lesion ahead of a deeply invasive or nodal metastatic lesion. And for that reason, they can oftentimes be more readily treated with curative intent by either surgery or radiation or both in that setting. So let's go on to one more of the lesions that we see in the squamous realm. And this is a less frequently encountered lesion, but is still one that merits your attention and awareness. Oops. If we can get it to the right spot here. This tends to be a very verrucoid, exophytic lesion as well, like the sarcomatoid carcinoma. But in contrast to that, we see very little in the way of atypia here. So if we look here at these surface fronds, yeah, there's a little bit of atypia here, but it's not very pronounced. And as you go up superficially, you just see this parakeratotic appearance. It's very papillary. It is verrucoid, if you will, has that wart-like appearance, and has the prominent vasculature in each of these cores. So laryngeal papillomatosis comes into the differential diagnosis. Other sorts of papillomatous lesions. And it's only when we get a full thickness biopsy that we can really see the nature of the interface here. And this is not an infiltrative lesion. It has a pushing pattern of invasion rather than an infiltrative budding type of lesion. It doesn't show the paradoxical keratinization to the same degree. Maybe a little bit of a suggestion there, but not very striking. But it does provoke something of an inflammatory response. And I think you can see there's some degree of apoptosis and atypia here at the very base or leading edge of this lesion. It shouldn't be juxtaposing these larger vessels. So this is a challenge when we only get a superficial biopsy. If we're just looking at the material that is up here in the papillae, we won't be able to make the diagnosis of verrucous carcinoma. But we can include that in our differential diagnosis, recognizing that this sort of marked hyperkeratosis and well-differentiated appearance can be the harbinger of underlying invasive carcinoma. So raising that possibility will help to alert the surgeon as to what type of lesion is involved and help them to get you a full thickness biopsy or some other resection or something of that sort to be able to make the diagnosis. So I think this is one of the harder diagnoses in head and neck pathology, just because the pattern of invasion is fairly subtle. It's the same dilemma we face in other organs where we have, pushing invasion as a criteria. I'm thinking of some of the mucinous tumors of the ovary have pushing pattern invasion rather than infiltrative or destructive invasion. So a very nice case, and this would be one that'd be valuable for you to study. So moving up to the sinonasal area, this is a lesion that you no doubt have seen. Just a very nice classic example of the features that we would associate with this. Rounded papillae with some inverting pattern growth, as you can see here. And this lesion characteristically has small little microcysts in it, along with neutrophils. So you see these inflammatory cells in this lesion, and you should immediately be able to think of inverting papilloma. No significant atypia, but obviously this is a lesion that can recur, and so excision at the time of frozen section or initial evaluation is desirable. But this one just demonstrates so nicely these little micro abscesses within the epithelial layer, along with the chronic inflammation underlying, and these cystic spaces within the mucosa. Really quite classical for inverting papilloma. Now, in contrast to that, we have this lesion, which is a little bit more exophytic type of lesion, and lacks the changes that we just talked about. It lacks the neutrophils. It does still have a degree of maybe microcyst formation. You see there's a little bit of a blue mucin to some of these cells. But notice we just don't have the neutrophilic component. So this is a true Schneiderian papilloma with the mucin producing cells of this type of lesion. So the mucin cells are pretty characteristic. The exophytic architecture is noted. There's more surface epithelium than there is inverting pattern epithelium. So an exophytic papilloma of the sinonasal tract with the accompanying appropriate epithelial cell types. Feel free to stop me at any point if you have a question or want to make a comment about things that I'm showing here. We'll go on here and show an additional lesion. This is a similar sort of pattern, an exophytic lesion, maybe a little bit of sort of mixed inverting pattern here. We've got some blood clot associated with it. But notice that as we look at these cells, how they look a little bit different. We've got far more of these little mucin droplets here. We have some neutrophils. And then also, as we look around, we see there's quite a lot of cytoplasm here. These lesions are very oncocytic. So this is within that same family of papillomas. This is an oncocytic papilloma with a combination of features similar to those of the inverting papilloma and to the exophytic Schneiderian papilloma. So that little spectrum and contrast, I think, is helpful to see these side by side and to recognize the differences. Now, in terms of behavior, I don't know that there's a huge difference in behavior although the inverting papillomas are more likely to be develop recurrences, I believe. Let's see, where's my... There we are. So this has a bit of a combination pattern of an exophytic and a partly endophytic lesion with the very oncocytic type of cells. So staying here in the sinonasal tract, another classical lesion that we encounter here in particular age groups is the olfactory neuroblastoma, typically in the apex of the sinonasal tract. Usually near the cribriform plate. And as you can see, this is kind of a blue tumor. Now, maybe more typically, you'd expect to see just fragments of this, in which case you've got the differential diagnosis for several other blue tumors like melanoma and plasmacytomas and so forth. But this lesion is quite characteristic and has these connecting cells. There's a connection to the cells. You have a very rich vascular background to this tumor. Notice that here, which you wouldn't expect to see with, melanoma or with plasmacytoma or others. You might see it with some of the neuroendocrine lesions in the sinonasal tract. And with some of the undifferentiated lesions. But I think you can also appreciate here, there's a very delicate fibrillar nature to the cytoplasm here. And this is one of the reasons where if you get a touch prep or something on this, you'll be able to bring that out a little more firmly. But there's a very delicate backdrop to these cells that is the neuroblastic component of that that shows you what is the backdrop for this. So small blue cells, that should prompt a particular workup for that differential that we've mentioned of neuroendocrine tumors, melanoma, plasmacytoma, and neuroblastoma. Of course, you'd also maybe consider sinonasal undifferentiated tumors and so forth as well. The whole differential of small blue cell tumors in the sinonasal tract is an interesting and challenging one. Here's another tumor that would fit into that differential. Let's pull it into a higher magnification here. We can see a very blue tumor, a fair bit of surface mucosa, and it's submucosal. And it's got a rich vasculature, but it's not the same pattern of vasculature that we saw. This is more a what's called the hemangiopericytoma type pattern, where you have these spindled blue cells with kind of gaping vascular spaces with very little in the terms of wall structure. So it's just like an endothelial cell and then tumor. So it's a very prominent stromal type of pattern. And this is a sinonasal glomangioma. Let's just make sure I'm giving you the right answer here. Yes, glomangiopericytoma. Indicating that these cells are pericytes, that they're going to have a pericytic pattern of morphology and immunohistochemical profile. Better prognosis, obviously, than olfactory neuroblastoma. Not with the same propensity of spread and so forth. Okay, let's do a couple more. These are in the salivary gland. We've covered some salivary gland lesions in the past. A very classical initial one. So you can see blue cell, sharp margins with a little bit of undulation, and composed of a couple of cell types, the sort of free-floating stromal cells and occasional ductal type epithelial cells or myoepithelial cells in this lesion. Pretty classical appearance for a pleomorphic adenoma. So I won't spend a lot of time on this one because we've covered this before, but for the sake of completeness, it's here. You can see the small ductal type formation to some of these cells, and then the spindle-shaped stromal cells with a myxoid background. Now, a related lesion is the monomorphic or basal cell adenoma, more properly termed, which is quite cellular, much less myxoid stroma, and has mostly a solid, but occasional small cystic spaces to the lesion. These, again, are generally well circumscribed and have a capsular appearance, and usually a fairly bland cytologic appearance. Now, there are basal type carcinomas that occur in the salivary glands as well. That would be the malignant counterpart of this tumor or this lesion. But those are decidedly rare and have more cytologic atypia, mitotic activity, and so forth to be harbingers or markers for them. Going on to other salivary gland carcinomas, the mucoepidermoid carcinoma, the most frequently encountered malignant neoplasm in the head and neck, salivary tumors at least. This comes in generally a couple of grades, but usually there's a predominance of the epidermoid component. This one has a little bit more of a balance, and you can see these isolated mucus cells within some areas of this tumor. Other areas are more predominantly mucoid, and so forth. So the proportion of mucoid and epidermoid neoplasia is quite variable. And at times, it may require that you do a Musi-Carmin stain to identify the rare cells here and there in a mostly solid tumor that have the expression of mucin. We use that a fair degree as a means of detecting and identifying these tumors. In a case like this, with a nice clear-cut mucin cells, that would not be a problem. But in the more solid and in some of the more poorly differentiated tumors, having the ability to do that Musi-Carmin stain or a PAS stain for mucin would be really quite important. And I would encourage you to obtain or get that capability in your laboratory if you're seeing very many neoplasms of the salivary glands. As I said, this one's quite easy because you've got quite a lot of these mucin cells here. You can make this diagnosis on the H&E. But in some cases where this is the predominant solid portion, you would want to have that additional evidence from a Musi-Carmin stain. Well, I guess we have time for one more here. And there's a couple more of these salivary tumors. So this is adenoid cystic carcinoma, and has a classical sort of jigsaw puzzle piece pattern with these nice mucin or cylindromatous appearance, punched out areas within the tumor. These can stain variably from blue to pink, as you know, and have a great propensity to invade around nerves. I think that's what this is here, is a small nerve, and here as well. So this is a significant tumor, but not one that usually is a difficulty in recognizing. when it has this abundant sieve-like pattern. When it's more solid, it can be a little bit more problematic and may require some immunohistochemical stains. Two other tumors that we should mention here in the last couple of minutes: salivary duct carcinoma. As you can see here, salivary gland rotted. And we see a tumor here that's centered around the ducts. And here, for example, is the in situ component of this tumor. Very oncocytic, very papillary. Sometimes the differential for this would be mammary-like tumor or mammary Anlage type tumor. But that is not the best diagnosis in this case because of the pattern and the lack of staining with HER2. In contrast, here, the mammary Anlage tumor would have strong HER2 staining and has again a reminiscent picture for breast carcinoma. Here with some retained normal ducts within the tumor and at the periphery of the tumor with a very abundant cytoplasm type of tumor. Well, I think we'll stop there. Hopefully I haven't misled you on anything here, because I'm not the expert on head and neck pathology, but I do like to look at interesting examples on this. And as I said, I'll share the link with this when I put out the video so that you can look at these slides and puzzle over the quiz questions that come along with them. So any questions from anybody before we wrap up? And you can go on to your day's work.
Yes. Yes, there are many cases in the neck, and I think it's very useful for me to review this case to remember them. Thank you.
Yeah, so yeah, just remember that the diagnoses on these cases are written on the slide, or you can click on that eye in the upper left that will give you more information about the particular case for self-study. Well, please keep sending me your interesting and challenging cases, and we will look forward to talking again the latter part of June. And until then, chúc mọi người mọi sự may mắn.
Cảm ơn giáo
Vâng, giáo sư.
sư.
Thank you,
See you.
Professor.
Thank you,
All right.
Professor.